talk about the acute abdomen. Okay. So again, please give me a few seconds for this. I just talked to Radalisai regarding her lecture on ward work. She's just going to give it on January. Okay, so take note, class leaders. That is on ward work. Okay, so this morning we're going to talk about the acute abdomen. Okay, and just a disclaimer. Okay, we're not going to talk about these kinds of abdomen. Okay, these kinds of abdomen are actually old school. Okay, we are now in the pandemic bodies. Okay, so this is more famous now, what we call the dad bad. Okay, so what is an acute abdomen? It is an abdominal pain and tenderness. It often has an underlying surgical problem. Okay, so that is why we talk about it. And this would need a prompt diagnosis and also surgical treatment. So again, if for my students in ward work, okay, I always emphasize this requires good history and physical examination, and is only complemented by your rational diagnostics. Okay, so we do not go from diagnostics to history and PE. Okay, or sometimes when we were in face-to-face ward work, okay, what happens is students go to the chart, they look at the diagnosis. For example, they see acute cholecystitis, okay, and then they fashion their history and PE from that diagnosis. So that's already too far back. And of course, I overemphasize that not all your acute abdomen are surgical. Okay, so not all your acute abdomen are surgical. Some are non-surgical. And if you look at your textbooks, there's actually a table there. Okay, the listing these possible causes of your non-surgical acute abdomen. Okay, they can be from endocrine, hematologic, okay, toxins and drugs, and even infectious. Okay, but of course, this morning we're going to talk about the surgical acute abdomen. Okay, and when we talk about pain, there are three types of pain that we have to discuss. Okay, the first one is your visceral pain. The second is your parietal pain, and the third one is your referred pain. Okay, so your visceral pain is usually vague, and it follows your embryological development. So structures that arise from the foregut, embryological foregut, refer their pain to the epigastrium. Structures from the midgut to the periumbilical area, and the hindgut in the lower abdomen. So if you look at this image, okay, you will see here where your different abdominal organs present. Okay, your parietal pain, on the other hand, is sharp and better localized, and actually follows your nerve roots. And your referred pain are distant from the source of pain. So visceral pain, okay, as I said, you have to take note of the embryologic origin. Okay, the foregut is divided from, of course, from the mouth down to your first part of your duodenum. Okay, so that is your foregut. Your midgut is from the second, from here it says the third or fourth part of duodenum up to your transverse colon. Okay, it includes up to two-thirds of your transverse colon, and the hindgut derivatives are from the last part of your transverse colon down to your anus. Okay, so if you have organs in any of those parts presenting with any disease, they could present on these planes. Okay, so again, foregut, midgut, and your hindgut. So visceral pain are usually due to obstruction, ischemia, or inflammation. Okay, and this causes the stretching of your unmyelinated fibers that innervate the walls or capsules of your organs, and therefore you now feel the pain. Okay, take note of this. Uh, take note of these factors, okay, that present with pain. Okay, it's stretching of your unmyelinated fibers. Okay, so it is a fact, okay, that even if you cut, okay, for example, you have an intestine that's open out in the open. Okay, even if you cut that intestine, you will not feel pain. Okay, because it has no fibers for that. Okay, but if you pinch one part of the intestine so that the proximal part starts to distend, okay, that is when you feel pain. Okay, so distension causes pain, ischemia causes pain. So we have, for example, your ischemia, for example, from a mesenteric artery obstruction, then you can feel pain. Okay, so it's obstruction, ischemia, and inflammation that actually produces pain. Okay, not the actual cutting of your intestine. So your visceral pain presents with crampy, dull, or achy pain. It can be steady or intermittent. The pain is poorly localized. Okay, and there's a table later that will be explaining why. Okay, intraperitoneal organs are bilaterally innervated, causing visceral pain to be felt in the midline. Okay, so even for example, your appendix, which is located normally in the right lower quadrant, when it first presents, you feel it in the umbilicus, okay, or sometimes in the epigastric area, and that is midline. Okay, so it does not visceral pain does not present on a lateral or does not have any laterality. Okay, so this is seen. Okay, this is a better table comparing your visceral pain and your parietal pain. Your visceral pain is have afferent C fibers innervating the walls of the hollow organs or the capsules of your solid organs, okay, like the capsule of your liver, the capsule of your spleen. While your parietal, you have afferent C and alpha delta fibers, which innervates the parietal peritoneum. Okay, so remember the parietal peritoneum, okay, is actually the wall, okay, the inner wall covering your abdomen. Okay, so this is stimulated by distension, again, distension, inflammation, and ischemia. Okay, so not cutting, okay, not burning, okay, unless it presents with your secondary inflammation or your ischemia. Okay, your parietal pain is stimulated by pus, bile, urine, and GI secretion. So all of this causes inflammation of your parietal peritoneum. So that is why your visceral pain is generally dull, poorly localized, mild to moderate pain. Okay, while your alpha delta fibers, they are responsible for the more acute, the sharper, and the more localized severe pain. Okay, so that is one clue that you are dealing with a visceral pain or a parietal pain. And when you have visceral pain, okay, the patient is constantly moving. Okay, a good a good example is your mesenteric artery ischemia. Okay, the patient would be moving about because of the discomfort. Okay, uh, the patient would not know how to position himself or herself. Okay, so probably when the patient arrives in the emergency room, patient would be sitting down. After a few minutes, patient would be standing, walking about. Okay, if the patient is in bed, he or she would be turning around. Okay, then you know that that is visceral pain. A patient with already with a parietal pain actually doesn't want to move. Okay, uh, patient, you usually see this patient in a crouch, okay, in a crouching position with the knees close to her. Okay, somewhat protecting his her abdomen so that it wouldn't be touched. Okay. Another good history is a patient with a parietal pain. They would tell you that on the way to the emergency room, okay, whenever there are humps or bumps in the road, okay, the patient would be crying in pain. Okay, so that is one clue that you are dealing with a parietal pain. So it says here not aggravated by coughing because they are constantly moving. A patient with parietal pain would be aggravated by coughing or even breathing. Okay, and okay, it says here may be more indicative of a medical condition. Okay, your visceral pain may be more. Okay, usually it's medical, and your parietal pain is usually surgical. Okay, remember the term when we use it in medicine. Okay, because nothing in medicine is 100%. Okay, so I cannot say that visceral pain are all medical conditions because there will always be exemptions to the rule. Okay, in the same way that a severe acute abdomen will not always be surgical. Okay, there will always be exceptions to the rule. Okay, so we discussed basics of your visceral and your parietal. And your referred pain is distant from the source of the pain. Okay, so for example, you have a heart condition or an inflammation of your diaphragm or your spleen or the tail of your pancreas. You can actually feel it in the left shoulder. Okay, so my shoulder here is painful, doc. Okay, and then the doctor tells you let's check your spleen. Okay, and you might say, oh, this doctor might be stupid. Okay, because I said I have a shoulder pain, and now he's trying to do test on my spleen. Okay, so we of course discuss the possibility of your referred pain to your patient. So in the same way, in the right shoulder, okay, patients who may have acute cholecystitis or acute hepatomegaly, okay, may have pain in the right shoulder. Okay, and why is that? And why is that? I think that slide was placed somewhere else. Okay, and why is that? Because they share the same nerve root. Okay, so for example, your C3, C4, C5 innervates, as we know, your diaphragm. Okay, also, okay, it's here, no, 3, 3, 4, 5. So it's the nerve roots are here. So it also goes to the shoulders. So if you have any inflammation in the diaphragm, in the liver, in the gallbladder, it can present as shoulder pain also. Okay, because the nerve fibers go up to the same root. Okay, and that's why your body is telling you you also have a right shoulder pain. Okay, so of course we cannot talk about acute abdomen in surgery without talking about peritonitis. Okay, so this is your most common cause of an acute surgical abdomen. Okay, and peritonitis is simply defined as inflammation of your peritoneum. And whenever you have a perforated viscous, okay, probably from a perforated peptic ulcer disease, or from acute appendicitis, or from a ruptured diverticulitis, okay, you actually allow intestinal contents to go out into the peritoneum. Okay, and after a while, you are going to induce your bacterial peritonitis because, as we talk about in your surgical infections, okay, not only does the skin have your normal bacterial flora, even your intestines. Okay, if you're going to test your intestinal contents right now, even though you're not feeling sick, you will get or you will grow a number of your bacteria. Okay, so your peritoneum is bacteria free. So for any disease that will allow intestinal contents to go into the peritoneum, you are going to induce your bacterial peritonitis. Okay, so that is why your ruptured appendicitis, your perforated peptic ulcer disease, peritonitis, okay, even your ruptured gallbladder peritonitis, for example, okay, would present with your bacterial peritonitis. And most commonly, these are gram negatives with or without your anaerobes. Okay, your anaerobes, we usually see them in your colon. Okay, so if you have colonic disease, then you think about your anaerobes. Okay, peritonitis can also be non-infectious, just like what we see in acute pancreatitis. Okay, so your pancreatitis can become your hemorrhagic, okay, pancreatitis. So it will allow all its contents, all its enzymes to go into the free peritoneum. Okay, and this will induce your non-bacterial peritonitis. Okay, we also have another concept called your primary bacterial peritonitis. And this is a diffuse bacterial infection without loss of integrity of the GI tract. Okay, we see this, for example, in patients with, for example, your shunts. Okay, patients with hydrocephalus, they have a shunt that goes into the peritoneum. Okay, if there's a CNS infection, this could go to your abdomen, and this can cause your primary bacterial peritonitis. In patients who are undergoing your abdominal peritoneal dialysis, okay, these patients can have peritonitis. So the way that we diagnose your peritonitis is because of severe tenderness, with or without rebound tenderness and guarding. Okay, if you see, I have highlighted the word without because this is a common myth. Okay, even in residents, okay, right now. So, for example, they call you in the middle of the night, Doc, I have this patient. I'm thinking possibly with acute appendicitis. There is direct tenderness, so that is so when you poke it, there's tenderness, but when you remove your finger, there's no tenderness, so that is what we call your rebound tenderness. Okay, and they say, Doc, I don't think this is already peritonitis. Okay, that's wrong. Okay, uh, peritonitis doesn't need to have rebound tenderness. Okay, when you already have rebound tenderness, it means that's already a long-standing peritonitis. Okay, it doesn't mean the absence of a rebound tenderness doesn't mean the absence of peritonitis. It's possible that you caught the patient early. Okay, that is why there is no rebound yet. Okay, but you have to act already. Okay, so we are going to emphasize on the history and physical examination of a patient with your acute abdomen. Okay, especially the surgical abdomen. Okay, so you will be prompted. For example, when you search in the internet, you will be prompted with this mnemonic, your PQRST. Okay, that is one way of remembering. So, for example, when you go to ward work already in face to face and you are interviewing a patient, this can be a good mnemonic for you to make sure that your history is complete. Okay, so we start with onset. Okay, if you see it's not in the PQRST, but you can easily add it. OPQRST, onset. When did you first feel it? Okay, and this will determine between the acuteness or the chronicity of the pain. In surgery, the usual cutoff is 1 month. When did you first feel it, Doc? I felt it 1 week ago. Okay, then this is an acute pain. Doc, I felt it 2 months ago, and then it disappeared, and now it's here again. Okay, so that's chronic pain. Okay, so of course you will have a lot of differentials that you are able to remove. Okay, when it is acute, okay, versus when it is chronic. Okay, so you have to ask the patient when. Okay, we start with the P. What are the provocative factors? Okay, or what triggers or worsens the pain? Okay, so of course you don't ask the patient that. What triggers the pain? Okay, so ask the patient, what were you doing? Okay, when you felt the pain. Okay, the patient will tell you, Doc, I was doing nothing. I was sitting down. I was watching the TV. Okay, or Doc, I was trying to push our refrigerator. Okay, because I wanted to clean the underside. Okay, and then I felt this pain. Okay, so that would tell of a different disease pathology. Okay, very important. For example, food intake. Okay, food intake worsens the pain from bowel obstruction, from biliary colic, and pancreatitis. Okay, so in bowel obstruction, if you are obstructed and you still take in food, okay, that will increase the distension of your proximal bowel. So again, this would worsen the pain. Okay, in biliary colic and pancreatitis, this will trigger, okay, your gallbladder to start pumping bile because of the food intake, and if there is obstruction, okay, or if there is inflammation, okay, the gallbladder will feel pain. The same with your pancreatitis. Okay. On the other hand, okay, for example, you know that if the patient tells you, Doc, when I eat, I actually feel less pain, or the pain actually completely goes away. Okay, so this is on the other hand talking about the palliative. What lessens the pain? Okay, and we usually see this. Okay, can I just? Okay, so this is on the other hand palliative. What decreases the pain? Okay, doc, when I take food, when I eat, it usually lessens. So here we're talking about your peptic ulcer disease. Okay, because of the hyperacidity, okay, when the patient tries to eat, the acidity is actually diluted. So your patient now feels less pain. Okay, so we've talked about motion. Okay, touching the abdomen or the car ride to the hospital. this worsens the pain in peritonitis. Okay, but in a patient with an intestinal ischemia, you would see him walking around. So these are provocative and palliative factors that you would have to ask. Quality. So you ask the patient, so what does it mean when you say it's painful? Okay? So remember, this is not a multiple choice question. Okay? Do not ask, is the pain sharp? Is the pain dull? Okay? You listen to what the patient will tell you. Okay? So the patient will tell you, uh, Doc, it's as if someone got a knife and started cutting inside my abdomen. Okay? Then you know that that's a sharp pain. Okay? Patients with aortic rupture will actually tell you, Doc, it feels as if someone tore something inside of me. Okay? So wait for these answers to be told by your patient. Okay, student. So do not give this information. Okay, or patient says, "Doc, as if someone is drilling or creating a hole inside my abdomen." Okay, region. Of course, you have to ask, where does it hurt? Okay, and we have been taught of this, either the four quadrant or the nine regions. Okay, that we have to take note of. Okay, of course, for pediatric patients, the four quadrant would be more practical. Okay, because we have uh, the patients still have a very small abdomen. Okay, and it's possible. Okay, that even an acute appendicitis can present in the left upper quadrant. Okay, if that is a very long appendix. Okay, it's possible that these pediatric patients may have pain in the left upper quadrant because of the size of their abdomen. Okay, in the adults, especially in very muscular or very obese adults, then the nine quadrant is more practical. So you can actually use this interchangeably. Okay, there is no textbook that will tell you that you only have to use this. Okay, and of course, it's very important to know your anatomy. Okay, and imagine what is under those quadrant. Okay, so for example, patient complains of a right upper quadrant, then you know what organs are in the right upper quadrant. Okay, your liver is there, your gallbladder is there. Okay, the head of your pancreas, your duodenum is there, part of your colon is there, of course, and your small intestines are ubiquitous; they're everywhere. Okay, so you can have these are the organs, okay, that you have to rule in. Okay, of course, if an adult patient is complaining of a right upper quadrant, don't tell me it's pelvic inflammatory disease. Okay, because that's already way below. Okay, so the region will, of course, help you to localize where that can be. Okay, so you may have a graph like this, okay, which will help you with your differentials. Okay, but of course, you don't have to be memorizing this. Okay, you have just to be aware of your anatomy. Okay, you just have to be aware of your anatomy. So you don't need to be memorizing a table like that. Like that. Okay, so that is if the patient can tell you where exactly is it painful. Okay, so we know that that is already of your parietal type. Okay, doc, it hurts here in the right upper quadrant. Doc, it hurts here in near the pubic symphysis, for example. Okay, so that's your localized. Okay, but most of the time, patients come to the emergency room and the pain is already generalized. Okay, meaning they cannot actually tell in what quadrant it's painful. Okay, They would tell you it's the whole abdomen that's painful, or they point to several areas. Okay, they will actually even start examining their abdomen while they are in front of you. Doc, it hurts here. Doc, it hurts here. Okay, so they will not be telling you of a specific area. Okay, then that is when you know you are talking about a generalized abdominal pain. Okay, and there are several reasons. Okay, for this is not a complete list. Okay, some authors would list other things. Okay, but what I like about this list, okay, is that there are several things that we have to consider here. Okay, first of all, most of the causes that needs prompt, very prompt treatment are actually surgical. Okay, like your generalized peritonitis, your mesenteric thrombosis, your dissecting or your ruptured aneurysm, your intestinal obstruction, all of these are surgical. Okay, and they need prompt treatment. Okay, but of course, being a clinician, you also have to be able to identify some of the non-surgical causes. Okay, like a patient with a sickle cell crisis, or patients with metabolic diseases. Are these patients diabetic? Do these patients have a thyroid problem, for example? Okay, so you also need to identify those because on patients who doesn't need an operation. Okay, and if that patient has a metabolic problem and you open it up, okay, thinking that it's a surgical problem, you might actually exacerbate the metabolic problem. Okay, so we need to think that there are some causes of non-surgical acute abdomen. Okay, for example, your diabetic ketoacidosis, your DKA, your alcoholic ketoacidosis, your AKA, patients with adrenal crisis, patients in thyroid storm. Okay, so these are metabolic. I added infectious colitis, although it's not metabolic. Okay, it's an infectious cause. Okay, but this can be non-surgical also. Okay, and the last thing that I want with this list is you have here psychogenic illnesses. Okay, and remember, okay, some that pain can be subjective. Okay, so for example, if I poke 10 of you, for example, I get a very fine needle, okay, and I poke. Okay, just even for example, with the recent vaccination, okay, you vaccinate 10 people, okay, you use the same size of the syringe, okay, and one or two people will tell you, Doc, it's very painful. Okay. Probably seven will tell you, Doc, I did not feel anything at all. Did you actually inject the vaccine? Okay, and then some people would say, Doc, I felt something, but it's okay. It's not that painful. Okay, so this tells us that pain can be subjective. Okay, and this has something to do with psychology. Okay, so we also have to be very mindful of that. Okay, there are times where we have had uh, non-therapeutic explorations. Okay, because we were not able to identify that these patients had uh, there is a psychological part to the abdominal pain. Okay, so that is also one thing that we have to be wary of. Okay, and the discussion of acute abdomen will never be complete without the discussion of acute appendicitis. Okay, and this is because acute appendicitis actually the journey, okay, or the timeline of acute appendicitis actually tells us the different levels of your pain. Okay, so in a textbook appendicitis, okay, the first few hours, okay, the patient will feel periumbilical or hypogastric pain, or not even pain. It's just a discomfort. Okay, so early on, first few hours, a patient will say, something's not right, okay? Or something is heavy in my periumbilical area. Okay, so that is the time when the patient is still presenting with your visceral pain. So the appendix is starting to get inflamed, okay? Possibly from a fecalite or possibly from lymphoid hyperplasia. Okay, so the abdomen is starting to get distended and inflamed. Okay, and then in a few more hours, okay, this appendix, okay, now touches the peritoneum near it. Okay, so it touches the peritoneum near it. So there's bacterial translocation because of the inflammation, and peritonitis, the peritoneum near this appendix also starts to get inflamed. So this is the time that your patient will tell you, now, doc, the pain has transferred to my right lower quadrant. Okay, so it starts to go down. Okay, from the umbilical area, it starts to go down. So now, from the pain that the patient was experiencing earlier, which was dull, okay, probably not even painful. He would say it's just a discomfort. Okay, now he will tell you, now doc, it's painful. Okay, so when you touch it, it's painful. When you release your hand, there's rebound. It's still painful. Okay, because you are actually causing a movement in your peritoneum. Okay, so this is the time that the patient is already presenting with your parietal peritonitis. Okay, so as I said earlier, you don't need to rebound. Okay, it's just possible that you poke it, it's painful. When you remove it, it's not yet painful. That's possible. Okay, but you already have your parietal peritonitis. Okay, and if this patient waits a little longer, okay, that appendix will rupture. Okay, and we have what we call like a honeymoon period. Okay, what is that honeymoon period? So imagine the appendix, okay, growing larger, larger, and larger because of the obstruction from a fecalite, for example. So it's growing larger, larger, larger. Suddenly it ruptures. Okay, when the appendix ruptures, the patient actually feels relieved. Okay, because the pressure in the appendix is no longer there. Okay, so ruptures, pack. Okay, the patient says, "Oh, now I'm better." Okay, but that actually takes only a few minutes to a few hours. Okay, after that, because of the release of the appendiceal contents, okay, all the succus inside, all the bacteria inside the appendix, now causes your diffuse peritonitis. Okay, so this is the time now that the patient will complain of pain all over. So this is now your generalized appendicitis. Okay, so at the later stage, patient is still presenting with parietal pain, but it's already diffused, or what we call your generalized acute abdomen. Okay, so this is a good. So acute appendicitis is actually a good case to discuss when we're talking about your visceral and your parietal peritoneum, peritonitis. Okay, so there is that. Remember, there is that honeymoon period. Okay, and if you don't get a good history and you miss that, okay, then there would be, especially when our society starts to become very litigious, okay, or every small problem they go to the court, they bring you to court, then this is a possible problem. Okay, I actually had that a case like that probably 2 or 3 months ago. Okay, this patient was seen by a surgeon somewhere in Lingayen. Okay, and probably saw the patient during the honeymoon period. Okay, so patient was complaining of pain, and then when the father brought the child to that surgeon, the child was already playing around. Okay, the child was already playing around. So uh, surgery was not offered. Okay, and then after a few hours, it became generalized. Okay, and the parents already lost confidence with that surgeon, so they brought the patient to the Gupan. So when I saw the patient was already in severe generalized peritonitis. Okay, and they were actually discussing in front of me, okay, how they are going to sue that surgeon because that surgeon did not see that. Okay, so I had to explain to them that these things happen. Okay, you have what we call your honeymoon period. Okay, or a time where the patient actually feels relief because of the rupture. Okay, so I don't know if that case was if they did pursue calling that doctor. Okay, but I would probably know when they start, when I would receive a subpoena to be the witness. Okay, but of course, I will tell them what I told them. Okay, that this is the natural course of appendicitis. Okay, so we've discussed about the region. Okay, we go to radiation. Okay, so this is the one I was telling you earlier. Okay, for example, you have a liver pathology. Okay, this could present as a right shoulder pain because they share the same root, which is your C3 to C5. Okay, for example, a patient has a urinary tract infection or a stone, okay, in the urinary tract, for example, in the ureter, in the pelvis of the kidney. Okay, the patient would feel scrotal pain. Okay, it's either flank pain here to the side, okay, which is very near to the kidney. That's easy to explain. Okay, or scrotal pain. Okay, and the patient will come to you, doc. Something's wrong with my scrotum, and you did your workup. The patient has stone up there in the kidney. Okay, and the patient will probably think this doctor might just be thinking of money because I came for a scrotal pain and now he's asking for a for example a kidney ultrasound. Okay, I think this doctor just wants to get more money. Okay, so of course we have to explain to these patients. Okay, this is referred pain. Okay, so scrotal pain or a labial pain, if it's a female, okay, can be a sign that there is something more up there. Okay, so you have to explain that. Otherwise, the patient, okay, will either lose confidence in you, go look for another doctor, even though that same doctor, that doctor explained the case properly to the patient, then the patient will stay with that doctor. Okay, so this emphasizes that as clinicians, we have to be better at explaining things to our patients. Okay, next in your PQRST is your severity. Okay, so you can ask the patient how painful it is. Okay, or you can show them these pain assessment tools. Okay, we have scales like this. Okay, the classical one was a round face. Okay, showing things like this. Okay, and of course, one thing that you have to remember is again, pain is very subjective. Okay, so for example, I've already seen patients who, for example, had a pinprick in his hand. Okay, this is a male patient. pain prick in his hand. Okay, so I think he was trying to pin something in his cork board, okay, and accidentally hit his hand. Okay, and when I showed him this pain scale, he gave me a score of 10. Okay, can you imagine? This patient is already thinking that he's going to die from that pin prick. Okay, so pain can be very subjective. So this severity pain scale is actually better at follow up, okay, and not as a baseline, okay? Meaning not as something that you would base your treatment on, okay? Because if this patient would say it's a level 10, okay, then I would say let's amputate your hand then, okay? So what do I mean by follow up? So for example, before treatment, the pain scale is 6, okay? And after treatment, the patient tells you, now, doc, it's 1. Okay, so I can, there's still pain, but it's already tolerable. Okay, then it becomes a very useful tool. Okay, but don't use it as the basis for your treatment. Okay, of course, there are other cues, okay, that you are dealing with a patient with severe pain. Okay, not just on what the patient will tell you. Okay, so this same patient who gave a pain scale of 10, okay, before I approached him, he was actually texting. Okay, so he was texting, possibly reading his Facebook, okay, watching TikTok. And then when I asked him, that's when he told me, Doc, it's a 10. Okay, so pain can be very subjective. Timing. Okay, so to differentiate this from the onset, okay, timing is to check how the pain actually progressed. Okay. Is this pain sudden onset? Meaning from zero, it became severe. Okay. From zero, it became severe. So, for example, we see this in intestinal perforation or arterial embolization. Okay. So, patient was probably watching TV or playing basketball, and suddenly it's very painful. They bring him to the hospital. Okay, so it's sudden onset. Okay, or it can be progressive. Patient feels pain level 1 on the pain scale 1. Okay, and then every day it becomes higher and higher until finally on the 7th day the patient could not tolerate it anymore. They bring the patient to the hospital. Okay, or is it intermittent? Okay, intermittent means it's on and off. Okay, so it's painful now after a few hours. When I rest a while, the pain goes away. Okay, and then when I start doing things again, it becomes painful again. So I rest again, and it goes away. So we call that also your colicky abdominal pain. Okay, and this could be secondary to your bowel obstruction, your biliary colic, for example, your intermittent bowel ischemias. Okay, so there's transient ischemic attack. Okay, and then your body was able to dissolve it. Okay, so patient is okay again, and then there's another blockade. Okay, so it becomes intermittent. So you have to ask also that from the patient. Okay, this is a relatively new addition to your PQRST. So I will tell you that during my time when I was a medical student and even when I was a surgical resident, okay, we stopped at T, okay, PQRST. Okay, and now we are beginning to understand, okay, that as I keep on telling through the history, that pain can be subjective. Okay, and we have to deal with what we call the patient psychology. Okay, some of the pain can be psychosomatic. Okay, So this is a pain, this is a physical symptom for which no medical reason could be established, or even if you're able to establish a medical or a even a surgical reason, you could see that it's totally disproportionate to your physical findings. So if we go back to that patient with a pinprick in the hand, okay, uh, why is this patient telling me that the pain scale is 10 when I can clearly see, okay, that he is able to look at his cell phone, play, look at TikTok, look at Facebook, okay? And yet when I ask him, he would say the pain scale is 10. Okay, number one, either he doesn't really understand the pain scale, so it's our job also to explain the pain scale. Okay, so is this pain so severe that you feel like you're dying already? And okay, or is this pain you feel it, but it's okay, it's tolerable. So you have to explain the pain scale, or the patient is saying it's 10 because of some other reason. Okay, and what are possible reasons? Okay, the patient may be seeking attention. Okay. Uh, we see this especially in children. For example, the lolos and the lolas are there. Okay, parents are there. Titos and titas are there. Okay, when you ask the patient or you examine the patient will be crying. Okay, as if the pain is so severe. Okay, but when you ask everyone to, can you please go outside so we can examine the patient properly. And now the pain is suddenly decreased. Okay, so it can be secondary to attention seeking. Some patients can use it as a manipulative tool. Okay, so again, we usually see this in children. Okay, mommy, my tummy hurts. Can you buy me ice cream? Okay, and then that patient will not be relieved until the parents buy the ice cream. Okay, so it can be manipulative. Okay, and of course, you also have to see the family dynamics. Okay, so to be able to understand that pain is very subjective, okay, it actually emphasizes two things. Okay, number one, that we have to treat our patients as a whole. Okay, and our job as clinicians is to heal and not just to cure. Okay, so curing means you just look at the physical illness. Okay, and if you're able to remove that physical problem, you're done. Okay, but that shouldn't be the case. So we have to treat our patients as a whole. Okay, and this includes the mind and the spirit. Okay, so for example, when we talk about breast cancer, for example, okay, we also talk about how will this patient with breast cancer cope up with removing one of her breasts. Okay, so even breast surgeons now talk about breast cancer support, psychology support for women who've lost their breasts. Okay, we know for a fact that the breast is a very important symbolism of the female body. Okay, so some women, for example, who has undergone modified radical mastectomy would feel that they are less of a person because they have only one breast. Okay, so just imagine if you're going to offer a bilateral mastectomy, for example, in patients who are high risk for breast cancer. Okay, for example, patient has breast cancer in the right. Okay, and you're able to find out, you did a genetic study, this patient has BRCA1, for example, and you recommend, if you want, we can remove the other breast now to decrease your risk of breast cancer. Okay, and you have to deal also with the psychological. Okay, so it is our job not only to heal the physical problem, okay, but also include the mind and the spirit. Okay, so our approach is to make the patients understand the reason, okay, and of course, to manage the expectation. Okay, you see here in the image the cycle of medically unexplained symptoms. Okay, patient is complaining of pain. Okay, and of course, when that patient feels the pain, there is uncertainty, there's fear of cause, okay, there's unmanaged expectations. So the patient becomes anxious. Okay, so the patient becomes anxious. He goes to Google, reads up a wrong article. Okay, and now the patient feels that he or she is dying. Okay, because Google told him or her that she will die in a few days. Okay, so the patient has more pain. So it's a vicious cycle. Okay, so our approach, okay, should be to give a better explanation, to manage the expectations, okay, and the patient will start to feel less pain. Okay, remember, it is possible that patients actually do have an actual physical problem. Okay, but sometimes the psychological part uh, over projects. Okay, meaning the patient is too anxious. Okay, for that physical problem that it actually feels now that, for example, the patient is dying. Okay, so just imagine that guy with a pinprick in his hand. Okay, he's giving a pain scale of 10. Okay, because patient is anxious, patient is misinformed, patient, the expectations were not managed. Okay, so even though we are surgeons, even though we are internists, okay, we still have to manage our patients holistically. Okay, of course, take note of other associated symptoms. Presence of nausea, vomiting, constipation, diarrhea, pruritus, melena, hematochysia, hematuria, etc. Okay. Vomiting, okay, when it is associated with severe abdominal pain, okay, then most probably that's surgical, okay, most probably mechanical bowel obstruction. Okay, again, uh, ask of the timing. Okay, did the vomiting occur before patient felt pain? Okay, so if there is pain before vomiting, that's usually surgical conditions. Okay, or was there vomiting first? So patient was vomiting for several days, but he was walking around. Okay, and then he felt the pain after. Usually, these are medical conditions. Okay, so for example, remember, in children, vomiting is the most common presentation of urinary tract infections. Okay, even actually in uh, teenage women, okay, or those at the age of less than 30. Okay, some of these women actually present with vomiting and not difficulty or painful urination. Okay, so if the vomiting occurs before the pain, those are usually medical condition. Okay, is the patient unable to move fecal material? Okay, if that is the main problem, okay, then you can give your laxatives or your prokinetic drugs. Okay, but if this is secondary, okay, meaning is there obstruction, then of course you have to identify the cause and relieve the obstruction. Diarrhea, for example, is one of, again, this is possibly one of the myths in clinical practice. Okay, patient has diarrhea. Okay, people always think that this is infectious. Okay, of course, majority can be infectious enteritis. Okay, but remember, some patients with peritonitis may present with diarrhea. Okay, so for example, in a patient with a ruptured appendicitis, the inflammation of your peritoneum can actually cause your intestines to move very fast because they're irritated. Okay, so they move very fast, and these patients can present with diarrhea. Okay, so diarrhea mostly can be infectious. Okay, but do not, especially if it's a prolonged part or it's very severe, or if there are associated conditions, then this might be surgical. Okay. Also inquire about the past history. Okay. Is there a previous illness? Okay. Or was there a previous surgery? Okay. I had a ward work before where the patient is already status post appendectomy. Okay. And then the students presented the case. Okay. Not this class. Okay. But previous batch. Okay. Patient is status post appendectomy. Okay, and then in their differentials, they put appendicitis. Okay, so of course, you already have a history that the appendix of this patient was already removed. Okay, so why is appendicitis now part of your differentials? So it shouldn't be there. Okay, surgical scars. Okay, so we know, okay, there's a different lecture on that, that your post-operative adhesions is the most common cause of surgical problem in a post-surgery patient. Okay, and the risk is there, okay, a few days after surgery to a lifetime. Okay, so even if the patient is already 80 years old and the patient had an explore lap appendectomy when he or she was 10 years old, okay, the risk for post-operative adhesion is always there. Okay, so it should always be listed in your differential. Okay, also ask, is this pain, especially for your chronic pains, is this pain similar to something you felt before? Okay, similar to something they felt before. So, for example, they were already admitted before because of renal stones. Okay, and the doctor, for example, did not operate, just gave him fluids. Okay, or probably even they did lithotripsy. Okay, and then but doc, that was years ago. Okay, but I think the pain is similar now. So you can go with your diagnosis probably the same with the previous illness. Okay, of course, previous illnesses that can recur. Okay, like renal stones. Okay, this can recur. Okay, if a patient already underwent cholecystectomy, okay, then do not make acute cholecystitis your differentials. Okay, it can be another biliary disease. So not the gallbladder because it was already removed. Medic. So ask the patient if he or she is taking any medication right now. Okay, of course, you also ask for is this patient taking anti-diabetic meds? Okay, so that will rule in your metabolic causes of abdominal pain. Is the patient taking narcotics for something? Okay, for example, patient has severe arthritis. Okay, and the doctor is giving him narcotics for the pain. Okay, doc, my knee is so painful, I couldn't sleep anymore. Okay, So the doctor said, okay, let's give you something for the pain and give you something for sleeping. So he gives a narcotic. Okay. So we know for a fact that your narcotics decrease bowel motility. Okay. So is this patient now presenting with obstruction just in ill use because of the narcotics? Okay. We know for a fact that narcotics is not the best pain medication for patients with biliary pain. Okay. So, for example, your patient is complaining of gallbladder stones. Okay. And still awaiting surgery, don't give narcotics. Okay. Because that will actually make the pain worse. Okay. So, narcotics also suppresses the pain sensation and even the mental status. Okay, so that is why one of the side effects is actually drowsiness. Okay, patients in chronic NSAID use, that's very common. Okay, and this will be at risk for your perforated peptic ulcer disease. Is the patient being given steroids? Okay, this will increase the risk for infections. Is the patient taking immunosuppressive drugs? Is the patient taking anticoagulants? Okay. Uh, is the patient, of course, you have this legal medication, but you also can ask about illegal medication, okay, like your cocaine and your methamphetamines, okay. This can actually cause intense vasospasm and may be mistaken for a cardiac failure or even an intestinal ischemia. Okay, so you have to take note of those. Of course, if your patient is female, then you have to rule out obstetric and gynecological history. Okay. Uh, if the patient is in the reproductive age, consider ectopic pregnancy. Okay. Mittelsmersh. Are you familiar with Mittelsmersh? Okay. Uh, some patients have been operated on thinking that it was acute appendicitis. To be found out, it's a negative laparotomy, okay, because of Mittelsmersh. Okay. Endometriosis, your pelvic inflammatory disease. Okay. What is postcoitus pneumoperitoneum? This is very interesting, and this only happens to women. Okay, so remember, if we study your peritoneum, okay, the female peritoneum has two defects. Okay, the female peritoneum has two defects, while the male peritoneum is a complete sac, no defects. Okay, the female peritoneum has two defects. Okay, and this is at the end of your fallopian tube. Okay, at the end of your fallopian tube, okay, if you look here, okay, that's an opening into the peritoneum. Okay, and interestingly enough, they were able to find out post-coitus or after sexual encounter, some women may present with pneumoperitoneum. Okay, there's free air in the peritoneum. So if you do an X-ray, there's free air. Okay, but the patient will not be complaining of any pain. Okay, in fact, the patient may be very happy. Okay, so post-coitus. So these are considerations in females. Okay, so after doing a very good and thorough history, of course, we go to your physical examination. Okay, so despite the wide availability of advanced diagnostic imaging, it cannot replace an organized and thorough physical examination. Okay, so this is why your professors is always emphasizing, okay, that you have to present a very good physical exam, okay, and not present a good CT scan, okay, or a good MRI. Okay? You have to have a good physical examination. Okay, and this picture is a very good depiction of that. Okay, so this couple is already stable. Okay, why would you want to destroy this stability? Okay, with CT scan. Okay, so first off, okay, if we're going to follow your physical examination, okay, we go with inspection. Okay, of course, even a few meters, okay, just approaching the patient, you are already starting your inspection. Okay, is the patient diaphoretic? Is the patient pale? Is the patient dyspneic? Is there decreased alertness? Okay, so this would tell you that you are dealing with a severe disease. Is the patient quiet, or is the patient very still in the hospital bed? Okay, then this might be a patient with peritonitis. Is this patient moving around, fidgety, okay, not able to stop at any one position? Then most likely this is not peritonitis. Okay, and then look at the contour of the abdomen. Okay, is it distended? Is it flat? Okay. Of course, we do not have many pathologies in the adult with flat abdomen. Okay, but for example, in pediatric surgery, if you have a baby with a scaphoid abdomen, okay, meaning it's the reverse of flat. Okay, you have a distended abdomen, you have a flat abdomen, and you have a scaphoid abdomen. So this can be a patient with a congenital diaphragmatic hernia. Okay, all the intestines are in the thoracic cage. Okay, so that you can see from inspection alone. Okay, then of course also look for surgical scars. Okay, so again, this will point you to possible diseases. Okay, look at erythema, look at ecchymosis. Okay, you're familiar with your ecchymosis. Okay, you have your Cullen sign and your Gray Turner sign. Okay, this could be signs of a retroperitoneal bleeding. Okay, so initially, your Cullen's and your Gray Turners was only used for your hemorrhagic pancreatitis. But now, they can be any sign of a retroperitoneal or even an abdominal wall bleed. Okay, so your Cullen sign and your Gray Turner sign. And then the difference with abdominal physical exam is we go directly to auscultation. Okay, so in other parts of the body, auscultation is usually in the last. Okay, but with the abdomen, we do it first after your inspection. Okay, it is done prior to your percussion or your palpation, because if you do your percussion and your palpation first, okay, you might actually trigger the bowels and they start to hyperreact. Then you will be reporting falsely that the patient is hyperactive. Okay, you have to listen for abnormal vascular sounds, your bruits. Okay, you have to listen for the bowel sounds. Okay, the character is actually more informative than the count. Okay, you've learned from Bates that the range of the normal bowel count is so wide. Okay, some textbooks say it's 5 to 20, 5 to 40. Okay, very wide. Okay, so what you actually want to hear is the character. Okay, if it is the normal is of course a very low pitch, sometimes hum. Okay, but if it becomes high pitch, okay, sometimes they even call it the metallic. Okay, then you are talking about hyperreactive. Okay, and this may be an early sign of your early obstruction. Okay, when you don't hear anything, it's very quiet. Okay, then this is your hypoactive. Okay, and this can actually be normal, or of course, if you have a distended abdomen, then this can be a late stage obstruction. Okay, and now you can go to your percussion. Okay, we usually use this to identify the liver span. Okay, and if you hear a dull resonance anywhere, that's not over the liver, that's not over the spleen. Okay, and this is in a distended abdomen, then think of solid tumor. Okay, so for example, you're in the umbilical area, there's a mass there, and you want to know, is this solid, is this cystic? Okay, then you can have your percussion. Okay, so if it is dull, then it's solid. If it's hyperresonant, or what we call your tympanitic, then it can be gas. So what does that mean? It can be distended bowels, or it can be pneumoperitoneum. Okay. Uh, you can also have diffuse dullness from liquid. So for patients who have ascites, okay, remember your fluid wave test. This is one way to check if there's actually if free fluid is actually causing the distension of your abdomen. Okay, so after your percussion, this is the time you go to your palpation. So this is actually the most informative portion of your physical exam. Okay, it localizes the source of the pain. It can tell you if you are dealing with a superficial or a deep problem. Okay, and if you have direct and rebound tenderness. So what is the proper position to do your abdominal exam? Okay, the patient should be lying in bed with the head slightly elevated, or you give a pillow. Okay, and then the knees bent like this. Okay, so that picture is they did not loosen the pants. Okay, so ideally you should loosen all the clothes. Okay, or if you're already sure that this patient is going to be admitted, you already change the patient to the hospital gown, so that when you do your physical exam, then there's already no pants there. Okay, because you have to loosen those pants to be able to do a very good physical examination. Make sure the room is warm, okay, and your hands are warm. Okay, because if your hands are cold and you touch the abdomen, okay, the patient will have a reflex guarding, okay, because of the cold and not because of the pathology. Okay, and talking about guarding, this could be voluntary or involuntary. Okay, so remember again, okay, that pain is subjective. Okay, so you have to be able to relax your patient to be able to remove this voluntary guarding. Okay, because if the patients think that what you're going to do is going to be painful, they would start to be they would start to guard their abdomen. So this position, okay, and of course your reassurance, okay, will remove this voluntary guarding. Okay, so if you've done all this, you've positioned your patient properly, and you've talked to your patient properly, you've put him or her to uh, more relaxed mode, and then when you start palpating and you feel the abdominal wall is tense, then that is your positive guarding. Okay, and this is involuntary. Okay, not any longer your voluntary. Okay, so this table is found in your textbook. Okay, most of the text here are from Sabiston. And these are some of the famous names under abdominal exam. Okay, like what is your Corvusure sign, what is Fothergill sign, what is the Murphy sign, obturator sign. Okay, so I know you're already familiar with all of this. Okay, and of course, the last part of your physical examination is your digital rectal examination. Okay, for example, during the face-to-face, the in the pre-pandemic, okay, it is always a cardinal sin not to do a DRE in patients with abdominal complaints. Okay, and I always tell my students, this is the time for you to be doing your digital rectal exams. Okay, because sometimes pediatrics, sometimes internal medicine will not ask for this. Okay, so it's during surgery that you actually have to insert your finger into the rectum to be able to do your DRE. Okay, and why is DRE very important? Okay, there are a lot of information that we can get. Okay, number one, is this a partial or a complete gut obstruction? Okay, if you insert your finger into the inner rectal area, okay, and you feel, okay, that if this is the inner rectal wall, if you feel that the inner rectal wall is tightly hugging your finger, okay, so that means there's no air in the inner rectal area. There's no fecal material in the rectal area. We call that your empty rectal vault. Okay, and your empty rectal vault is a sign of a complete gut obstruction. Okay, because even gas cannot go beyond the level of obstruction. So this means you have lesser time to prepare your patient for surgery. Okay, you have less time to prepare your patient for surgery. Okay, for the fear of, number one, patient going into sepsis. Okay, if patient is already septic, it will be more difficult to pull him up. Number two, patient can have a bowel rupture soon. Okay, and if that bowel rupture happens, you're going to have a more difficult time with surgery. Sepsis will come in, and you will have a difficult time pulling up your patient. Okay, but if you do a rectal exam, okay, and you feel there's still air, okay, there's some fecal material there in the inner rectal area, then you are dealing with a partial gut obstruction. So you have more time to prepare your patient. Of course, we would like to have more time, okay, in whatever we do, correct? Okay, more time to study. It's already the finals. Okay, more time to read, more time to watch, more time. Okay, in this case, we want more time to prepare our patient for surgery. Okay, once you pull out that finger, you look at the character of the stool. Okay, what is its taste? Okay, just joking, don't do that. Okay, so what is its character? Okay, is there blood admixed? Okay, is the stool color black? Okay, then you know that there is melena up there. Okay, because of the black tarry stools. Okay, um, what else? Is it solid? Is it semi-solid? Is it liquid? Okay, all of this will tell you or point you to a specific pathology. Okay. You also see, do you have parasites? Okay. Sometimes even just looking at the rectum or the anus, okay, you can actually see very small worms. Okay. That's possible. Okay. Or you can see sometimes in a patient who is very irritated. Okay. When you do a rectal exam, you can actually get also ascaris when you pull out your finger. Okay, because the ascaris are thinking, oh no, this patient is about to get septic, we have to get out. Okay, so sometimes when we put NGTs, okay, they follow the NGT. So a few hours after, you see ascaris coming out from the NGT tube or coming out of the mouth. Okay, sometimes even intubated patients, you see ascaris coming out of the ET tube. Okay, and here in Region 1 Medical Center, we've had several cases of patients presenting with acute abdominal pain. Okay, the residents call me, Doc, I think it's ruptured appendicitis. Okay, when they open up, the appendix is viable and they see what? Ascaris bolus. Okay, so the volume of ascaris is so high that they actually formed a ball inside the intestine and caused obstruction. Okay, so parasites. In older men, okay, of course, you have to identify the size of the prostate. Okay, the prostate can be so large, it can cause not only urinary obstruction, but even rectal obstruction. Okay, and if you're one of your differentials is appendix, okay, you can actually identify where the tip of the appendix is. Okay, if you do your rectal exam and there's pararectal tenderness, then you know that your appendix, the tip of your appendix is somewhere pointed to the pelvis. Okay, we know for a fact that the appendix can go anywhere. Okay, we've had a case where the presentation is a left upper quadrant. Okay, left upper quadrant pain, not right. Sorry, right upper quadrant. Okay, not right lower quadrant. Okay, when we opened up, okay, the tip of the appendix is very near the liver. That's why the presentation is right upper quadrant. Okay, or we've had patients where both the visceral and the parietal signs are in the umbilical area, not in the right lower quadrant. Okay, because the tip of the appendix is actually very near the umbilicus. Okay, so if the tip of the appendix is in the pelvic area, okay, you can feel your pararectal tenderness. Okay, of course, if you have a female patient, okay, then you must also do your pelvic examination, okay, or your internal examination, okay, and your bimanual, okay. So meaning one finger into the rectum, inner rectum, one finger in the vagina, okay, your bimanual. Okay, so you've done a good history, you've done a good physical exam. Okay, we now go to your rational diagnostics. Okay, so make sure where before you go or before you order your diagnostics, you already have a primary working impression and your differentials listed. Okay, do not go into your diagnostic without those. Okay, otherwise you will have to request for everything. Okay, you would have to request for everything. Doc, let's request CT scan, X-ray, ultrasound, MRI, PET scan. Okay, by the time everything is done, your patient already has no money for treatment. Okay, no money for treatment because you've used all his or her resources just for the diagnostics. Okay, and that actually looks bad on you as the clinician, okay, because it just means you did not get a good history and PE, that you were not able to come up with a good primary working impression and shortlisted your differentials. Okay, so it doesn't mean that the patient is very rich that you can request for everything. Okay, or if you look at the charity hospital, okay, it doesn't mean that the patient will not be putting out money because he is a charity patient. Remember, the government is paying for that. Okay, the government is paying for that. Okay, so if you're going to request everything and the allocation for that patient is already used up, then that patient will actually start coughing out money already. Okay, so all our patients in the charity hospital, okay, has allocations depending on their disease. Okay, so for example, your patient uh, was operated on for acute appendicitis. Okay, so there's a specific amount for acute appendicitis. Okay, but for example, it took you MRI, CT scan, ultrasound to diagnose acute appendicitis. Okay, then just imagine this patient will no longer have enough allocation for the treatment. So this patient will start paying for the other cost. Okay, so this is the concept of your rational diagnostics. So all the diagnostics that you will request should be rational and should be useful for you to rule in or rule out important diseases. Okay, so for the laboratories, of course, we need our complete blood count with differential count. Okay, you need your electrolytes. We know for a fact that hypokalemia can cause ill use. Okay, so if the patient is presenting with ill use and there are no other indications that he needs surgery, then we correct that first. Probably that's the one causing the ill use. Yes. So these are not this list is shouldn't be done in all patients. Okay. Probably the only thing that we do as a routine is your CBC and your electrolytes. Okay. So if you have, for example, a jaundice patient, then that's the time you request for your liver function test and your hepatitis screen. You're considering pancreatitis, that's when you request your amylase and lipase. Okay. You're considering bowel ischemia, then you request for your ABGs. Okay, you look for the if this patient is in severe metabolic acidosis. Okay, then you know that this patient is in bowel ischemia. Okay, your urinalysis, we can use that for our female patients in reproductive age. Okay, because you can add your pregnancy test. Okay, so if you have a patient who is pregnant, this could be ectopic pregnancy. Okay. Remember, especially for example, in very young female patients who are in the reproductive age. Okay, when the mother and the father is around, okay, or the lolo and the lola, the titos and the titas are around. Okay, if you ask them, have you had already a sexual experience? Okay, then definitely the answer you will get is no. Okay, and you will be surprised that these patients will have positive pregnancy test. Okay, so you would think, oh my God, this is a miracle. Okay, this is this the new Mary? Okay, so no sexual contact, but the patient is pregnant. Okay, of course, the answer is they will not uh, tell it to you. Okay, especially if the parents are there. Okay, so sometimes when we are taking our history, we send the parents off. Can you buy this or can you please get this? And that's the time we ask the child. Okay, we've seen 10-year-olds, okay, 11-year-old, 12-year-olds who were pregnant already. Okay, remember, uh, once you start having your menstrual cycle, okay, then this is a sign, okay, that you are already producing eggs, okay, and they can be fertilized anytime. Okay, so that's very important in your history. Okay, so we can so if the patient still says no, doc, no sexual experience yet, then you can actually request urinalysis with pregnancy test. Okay, ultrasound. So some surgical diseases, okay, the best imaging is ultrasound. Okay, and we know this for our gallbladder stones. Okay, it's cheap, it's readily available. Okay, and in hospitals where there is an ultrasound machine in the emergency room, then this can even be surgeon performed. Okay, so just to tell you, okay, especially for those who wants to be a radiologist, okay, there is now a growing trend for non-radiologists to perform your basic ultrasound. Of course, your basic ultrasound, okay, not the complicated ultrasound that radiologists do. That's still under their practice, okay. But for some basic ultrasound, like ultrasound for gallbladder stone, okay, so surgeons can perform this, okay. So for example, when I was still under training in the Philippine General Hospital, if you are under the hepatobiliary service, okay, we do our ultrasound every Wednesday. Okay, so every Wednesday, of course, our fellows does most of the ultrasound. Okay, but when they're already tired, okay, they can ask the resident to do it. Okay, they will be there watching, of course, if you're doing it right. Okay, and sometimes we do ultrasound on 30 to 40 patients a night. Okay, 30 to 40 patients a night, just identifying gallbladder stones. Okay, so that is already basic for surgeons. Okay, also we have what we call your FAST. Okay, your focus assessment with sonography for trauma. Okay, we have we have an ultrasound machine in the emergency room, and patients who need to undergo FAST. This your FAST is a surgeon performed ultrasound. Okay, so this is of course legal. Okay, we don't we just do the basic ultrasound. So for example, we have societies now of clinicians who do ultrasound. For surgeons, we call it the PISUS, okay, the Philippine Society of Ultrasound Surgeons. Okay, internal medicine has a society for IMs who do ultrasound. Anesthesia has societies for doing ultrasound. Okay, so this is already a global trend. Okay, we can use ultrasound in children when the diagnosis of appendicitis is not straightforward. Okay, we do ultrasound more than CT scan because we know for a fact that in children, there is very little fat yet in the area. Okay, and CT scan needs that fat to be able to distinguish between tissues. Okay, and ultrasound is done more. Okay, in older children, we can go with CT scan. Okay, there are some diseases that you actually need just a plain abdomen. Okay, and always remember, this should always be a partner. Okay, you have a supine and upright X-ray. For children, the cross-table lateral is the equivalent of your upright. Okay, and plain abdomen is best for your intestinal obstructions. Okay, also this your plain abdomen can also identify perforations or free air in in the peritoneum. Okay, but if you see, for example, an intra-abdominal tumor, then your X-ray becomes just screening. Okay, we need CT scan for that, for your solid tumors. Okay, and the reason for that is we need to see the size of the tumor. We need to see the intimate relations. We need to see the blood supply of the tumor. Okay, so that's why we need a CT scan. Okay, so by X-ray, you can actually see, so these are X-rays of intestinal obstruction, and you can actually differentiate between a small bowel obstruction and a large bowel obstruction. Okay, for your small bowel obstructions, you can actually see the valvulae conniventis or your plicae circularis. Okay, you see that here. Okay, you see complete divisions. Okay, so this is the intestine. Okay, and you can actually see complete divisions. So that is your plicae circular. Okay, so it's circular. In your large bowel, you don't see it complete. Okay, like here. So it stays there, it doesn't go to the other side. Goes here, doesn't go to the other side. Okay, that is what we call your haustral markings or your haustra. Okay, so that is one way of differentiating your small and your large bowel obstructions. Okay, what do we see with the upright film? With the upright film, okay, like here. Okay, so what does it mean? Your patient is sitting down or standing up. That's why it's called upright. And what do we look for in the upright film? We look for the level of obstruction. So what is the most distal bowel that is distended? So if you look at this, okay, and you follow it, you see here, okay, this is the most distal bowel that is obstructed. So you know, or you can surmise that the level of obstruction is at the descending colon. Okay, it's either the descending colon or the early part of your sigmoid. Okay, so that is your level of obstruction. You can also see air fluid levels. Okay, so in the upright film, the air fluid levels, okay, the fluid will actually make a straight line. Okay, it will make a straight line. And you will see your pneumoperitoneum. In your supine film, you can see the diameter of your distended bowel and the gas patterns. Okay, so the CT scan will tell you what ultrasound and the plain film cannot specify. It's best for tumors. It delineates size and extent, identifies involved structures. It assesses resectability, and it assesses recurrence. Okay. Of course, the number one problem with CT scan is your radiation. Okay. Of course, you expose your patient to radiation. Okay, so this is a case that we've had just this week. Okay, patient is YV, complaining of recurrent abdominal pain and vomiting. So the patient was admitted 7 times already before and goes home, then readmitted, goes home, okay, recurrent abdominal pain. So when we requested the ultrasound and the x-rays during those uh, admissions were said to be normal. So we requested for a CT scan, and that was when we were able to identify your midgut volvulus. So this is the intraoperative picture. Okay, you actually see here, okay, the twisting. Okay, so this set of bowels twisted on this very small axis. Okay, so that's your midgut volvulus. Okay, your diagnostic laparoscopy can also be used for your diagnosis. And laparoscopy has been very helpful because can you imagine in the past, if you have a patient with normal imaging, but the pain persists, okay, you would tell them, we need to open you up. So you're going to do a diagnostic laparotomy. Okay, meaning you have to make a very big incision, okay, just to be able to look inside the abdomen. Okay, and then look what are the possible causes of the pain. Okay, with the diagnostic laparoscopy, okay, that very large incision, okay, can now be just a very small incision where you put your camera. Okay, so with that, you can twist your camera and look around. Okay, you can insert additional instruments so that you can move bowel, okay, to look under some structures. And if you are not able to find anything, you can pull out your instruments, okay, and that's it. If you're able to find anything, you can actually do therapy. So it can be both diagnostic and therapeutic. So, of course, sometimes there are patients where we really do not have or really do not need a specific diagnosis. Okay? So these are your indications for immediate laparotomy, okay? Or your immediate exploratory laparotomy. In some cases, a specific diagnosis is not needed. When? Number one, pneumoperitoneum. So in this upright x-ray, okay, you always look for the free air on the right side. Okay, remember, on this side, your liver should be here. So there should be no free air there. Okay, so this is a very good place to look because even if you only have a very thin, okay, because not all pneumoperitoneum are have a very big pneumoperitoneum. Some, if you catch them very early on, the pneumoperitoneum is very thin. Okay, it's just a sliver of black line. Okay, then that is already an indication to open up your patient. So you don't need to identify, is this ruptured appendicitis? Is this ruptured bowel from diverticulitis? Is this ruptured gallbladder? Okay, you don't need to identify that. Okay, you already have pneumoperitoneum, so you need to open up your patient. You have sepsis with no other region to explain it. Okay, sometimes our counterparts from IM or pediatrics would refer a patient with sepsis. Doc, I've already ruled out pneumonia or respiratory problem. I've already ruled out CNS problem. There are no soft tissue causes, sources of the sepsis. Can you please look at the abdomen? Okay. So sepsis with no other region to explain it. Okay, we can do your laparotomy. Penetrating abdominal trauma. Okay, when we say penetrating, is it secondary to a gunshot wound, secondary to a stab wound? Okay, then you have to do immediate laparotomy. Okay, patients who are hemodynamically unstable in patients presenting with a GI bleed. Okay, so we know for a fact that a large majority of GI bleeds resolve on their own. Okay, patient comes to the hospital, there's GI bleeding, there's melena, there's hematochezia. Okay, what do you need to do? Put an IV line, resuscitate the patient. If there is a need to transfuse blood, transfuse blood. Okay, but if this patient continues to need blood, okay, or there is already hemodynamic instability from a bleeding intestinal cause, then you need to do immediate laparotomy. Okay. If you have evidence of hypoperfusion, these are for your mesenteric ischemias. And I said earlier, we do our ABGs. Okay, and if you have severe acidosis, okay, severe acidosis with no other causes, then this could be a sign that you are having a intestinal ischemia. Open it up. Okay. Patients with closed loop obstructions. What is the problem with closed loop obstructions is your abdomen is not that distended. Okay, because there's only a very short loop of bowel that uh, obstructed. Okay, if you look at this X-ray here below, okay, this is an X-ray of a volvulus. Okay, so that means you have a closed loop obstruction. Okay, so even if the abdomen as a whole is not distended, you actually have one loop that's distended. Okay. Of course, even if you have a patient with a medical condition, okay, uh, our partners still refer to surgery, okay, and we co-manage that patient. We observe because it's possible, okay, that in the timeline of any patient with a medical condition, they might need possible surgery. Okay, so for example, a patient who is being observed for diabetic ketoacidosis, okay, is in the hospital already for 2 weeks. Okay, and then there's a change in the abdominal pain. It became more severe. Okay, so the surgeon can be called, okay, to see, okay, what are the possibilities. Of course, you can still develop appendicitis in a patient with diabetes. Okay, you can still develop gallbladder disease in a patient with diabetes. You can still develop intestinal ischemia in a patient with diabetes. Okay, so how do we prepare our patients for surgery? Okay, of course, this is a ward work question. Okay, you have a patient whom you are preparing for surgery. What will you order in the chart? Okay, of course, the first one is your non-per-os or your NPO. Patient will not be allowed to eat or drink while we are preparing the patient. You insert your NGT for proximal decompression. Okay, insert the largest available. Okay, that will still be comfortable to the patient. Okay, for example, in our neonates, okay, newborns with intestinal obstruction, we can insert even as large as your French 12, French 14. Okay, but we don't insert it in the nose. Okay, we insert it in the mouth. Okay, it's called an orogastric, not a nasogastric. It's orogastric. Okay, and if you have a larger tube, it will decompress your bowel faster. In some patients where the cause of obstruction is more distal, is it anorectal or rectal, you can insert your rectal tube. Okay. Of course, insert IVF. Okay. You have to correct for the dehydration status. Insert your Folicat to monitor your urine output, and this is an objective feedback of your resuscitation. Okay. So meaning, if your patient has a good, acceptable amount of urine output, then you are doing a good job at resuscitation. Okay? So we said earlier, you have to start your empiric antibiotics. Okay? When you are, especially when you are preparing for obstruction. Okay? Even if there is no rupture yet of your intestine, you have your bacterial translocation. Okay, so that's why patient with obstruction, even if there is no perforation yet, they can have bacterial peritonitis. Okay, because of their bacterial translocation. Okay, when you already have your diagnosis, okay, again, this is one of the myths. Okay, uh, they say that if you are dealing with a patient with abdominal pain, do not give pain meds, okay, because this will mask the pain, okay, uh, in a way that is correct, okay. If you are still diagnosing, you don't know yet what is causing the pain, then don't give your pain medication, okay. But if you already have a diagnosis, okay, then of course be humane. Okay, so start giving your pain medications because you're already preparing your patient for surgery anyway. And then you monitor your patient for changes. Okay, the clinical status of your patient is always volatile and dynamic. Okay, so it's not static. Okay, so it's 12 o'clock, past 12 o'clock. Okay, the last part are your special patient populations. Okay, your pregnant women. I'm just going to give you the summaries. Okay, pregnant women, It's actually safe to operate on pregnant women. Okay, you can either do open or laparoscopy. Of course, we do our laparoscopy in the second trimester. Okay, the uterus is not that large to restrict your laparoscopy. Okay, and then not too early to cause premature delivery. Okay, if for example you have a disease that you can delay surgery, we either delay it to the second trimester or delay it long enough after the mother has delivered. Okay, but of course, if you cannot delay it anymore, for example, it's a ruptured appendicitis in a pregnant woman, okay, then you have to explain to the parents, okay, that the life of the mother is primary over the life of the child. Okay, because there's a possibility. Number one, sepsis can kill your fetus. Okay, even the sepsis alone can kill the fetus. Two, the surgical procedure might induce premature labor, and therefore you will have a premature baby. Okay, so you have to explain the life of the mother is, of course, primary over the life of the child, unless, okay, the patients will say, no, doc, the life of the child is more important than the life of the mother. But I don't think there's someone who would prefer that. Okay, but we've seen stories like, for example, the mother is a cancer patient who unfortunately still got pregnant. Okay, then uh, they can choose to have the life of the child over the life of the mother. Okay, pediatrics children are very poor historians. Okay, you cannot ask a 1 year old child what happened to him. How can he explain the pain? Okay, therefore, there are other things that we have to follow. Like, for example, bilus vomiting is always prompt for further investigation. There are some diseases that present at certain age groups, okay, like your intussusception. Your idiopathic intussusception goes at the age group of 3 months to 3 years old, okay? And of course, you have to refer to your pediatric surgeon for this. Okay, patients who are in critical illness, patients in the ICU, okay? Of course, they will always be a challenge because of their presence in the ICU. There will always be delays in the presentation of symptoms. Number one, because of your narcotic analgesia, okay, and blunting of the inflammatory process. In some cases where the CT suite is too far from the operating room. So most of your ICUs are actually near the operating rooms. Okay, if you go to our private hospitals, most of the ICUs are near the operating rooms. Okay, so sometimes it would be easier to bring the patient to the operating room than to the CT scan. Okay, uh, we've had some cases like that. Uh, for example, I had a case where it was not safe, okay, for the patient to be brought to the echo, okay, because for example, this particular hospital, if we're going to request to the echo, we're going to bring the patient to another hospital, so they cannot do it in that hospital. So the doctors decided, okay, that it would be easier to bring the patient to the operating room, okay, and deal with problems later on than to bring this patient to the echo, to the other hospital. Okay, so there are situations like that. Okay, immunocompromised patient, almost the same problem as your ICU patients. Okay, other special cases, patients with cardiac, morbidly obese elderly, and advanced cancer. Okay, so that is this is my last slide for your acute abdomen. So you're going to have one more lecture in general surgery, and Dr. Acevedo will take the slot of pediatric surgery this Friday, so that all your subjects, all your lectures in general surgery will have been finished. Okay, and then we'll have your second long next Wednesday. Okay, remember your general surgery has a higher percentage than your other subjects. Okay, like your pediatric surgery, orthopedics, anesthesia. Okay, so you have to review well. Okay, in general surgery. And then what else? So I was informed your anesthesia has been exam has been moved to this Saturday. Okay, so good luck, everyone. God bless. It's already finals week. Okay, so I hope you are in finals mode already. Okay, so this is not a time to be relaxing. This is already your finals week. Okay, we've had a glitch with the exam yesterday. Okay, I'm still trying to figure it out. I've also notified the app creator for Kilgo to identify what went wrong. Okay, but we will still be using Kilgo and Google Form for our next exams. Okay, any questions? Not necessarily in general surgery, not necessarily on the lectures, on the technicals.
The question po regarding the shifting exams sa ward work po, Doc. Since Dr. Adalice will have her plenary on January po, will we still proceed with the surgery ward work shifting as a class po?
Okay, we can have we must have the end of the semester exam. Okay, so that we can finish, so that you will have a grade for ward work after the first semester. Okay, so we'll schedule that next week also. Okay, so that before you go to second semester, you already have an idea of where you stand. Okay, so the problem we've had with the last year is that all the grades were computed at the end of the year. So some students who thought they were doing fine, okay, there's an illusion of what do you call that? Illusion of doing fine. Okay, probably they will have to add that to the list of illusions. Okay, illusions of grandeur. Okay, illusions of doing fine. So students will email and say, "Doc, I was doing fine. Why did I fail?" Okay, and when you look at the exams, they're not fine. Okay, so our goal is that before you start the second semester, you will already know how you stand in the first semester. Okay, so that you can drive yourself more if your standing is not good. Okay, if you have a good standing, then keep it up. Okay, so that's our goal. Any other question?
But what would be the coverage though of the end of the semester exam for surgery ward work?
Okay, what we will do is that the different ward work professors will be giving their contributions. Okay, so this means it's going to be a generic exam for everyone. Okay, so of course, discussing more on ward work. So we will be asking, and I already received some exam contributions from the professors. So even if you did not go through that professor, that professor will be contributing some questions. Okay, any other question?
Good
There's
morning.
a question here. Sorry. Who was that?
Sorry po, Doc. Mary Rose De Leon.
Yes.
Was the concern po regarding power interruption po on Saturday, if there is any chance po, Doc, to reschedule po it.
In what locality is the power interruption? Here in Dagupan?
Mapandan or Daneta po, some parts of Villasis po, Doc. I sent the notification from Panelco po, Doc, to the officers po, Doc.
Is there a big group of students from that area? Okay, because from what Elijah has forwarded, you already have several exams on Saturday. And that would include pediatrics and now pediasurgery and anesthesia. That's just for surgery. You have other exams yet. So, do we have a big group of students in that area? Yes, go ahead. I'm sorry, who was that? Nagabarga.
Hello, for Doc. Even in India, it's second Saturday in India, Doc. So we will be having a power interruption, Doc, on Saturday.
What time?
It will be from 7 a.m. to afternoon 1 p.m., Doc, in India, according to IST.
So for that, we can have the exam in the afternoon.
No, Doc. If in afternoon 1 o'clock means in Philippines, it will be 4:30, Doc.
Okay, I need a list of students from the Mapandan area, as according to Dr. Mary Rose. And then I need a list of students who are in India who will be affected by that interruption. Can you post it in the stream today?
Doc, Mangaldan also. Whole municipality of Mangaldan. On Saturday po.
For San Manuel din po.
Okay, then I think the solution is to have it on a Saturday night or a Sunday. Because we cannot delay it much further. Okay, remember, after the second long exam, you will have your finals exam. So it's a long 2 weeks of exam. Okay, so give me that list or at least just a number of students. So if we have enough students, then we can reschedule the exam on the evening or Sunday. So that can be our possible solution.
Okay po, Doc. Send ko po later yung list of students and the areas affected po.
Okay. There's a direct message to me here. Good morning, Doc. My roommate, who is a clerk, is having exam on December 18. Same timing with pediatric exam. So what does this mean? Does this mean that your internet connection is so poor that you cannot have two people taking the exams?
No, Doc. I mean, like, if he will also use the Zoom and for proctoring, and I will also use the Zoom for proctoring. So there will be like glitches in mic. That's why I'm asking, Doc.
It's okay if because you're going to take different exams. Okay. In the IM exam yesterday, I hear a feedback. Okay, so meaning there are two of you who are in the same room. Okay, but no one claimed to be that way. But I can hear feedback. So you can only hear feedback if there are two gadgets open in the same room that are in the same session. Okay, but if you are in different sessions, you are in a pediatric surgery exam and your roommate is in a clerk's exam, then there's no problem with that.
Okay, Doc. Thank you.
What rotation is that?
Doc,
What rotation is your...
Doc, they have comprehensive exam.
Okay. In the college.
Doc, no, Doc, they have online exam. He informed me that they will have online exam.
Yeah, I mean in the college, comprehensive exam in the college, not in a specific rotation.
Yes, Doc.
Okay. There's a question in the chat room that is not connected to our topic. I will just answer you personally later. Okay. Okay. So if there are no other questions, then let's break for lunch. So goodbye, everyone.